Welcome to Lesson 1 of your Intrapartum unit. In this lesson, we will cover the concepts associated with pain management in labor. Upon completion of this lesson, the student should be able to describe the breathing and relaxation techniques used for each stage of labor, identify non-pharmacologic strategies to enhance relaxation and decrease pain during labor, to compare pharmacologic methods used to relieve pain in different stages of labor and for vaginal or cesarean birth, describe nursing responsibilities appropriate in providing care for a woman receiving analgesia and anesthesia during labor. Pain during labor and birth. The pain of childbirth has two neurologic origins: visceral pain from the cervical changes, distension of the lower uterine segment, and uterine ischemia. Visceral pain is located over the lower portion of the abdomen. Referred pain originates in the uterus but radiates to the abdominal wall, lumbosacral area of the back, iliac crest, gluteal area, and down the thighs. Somatic pain occurs during the second stage of labor. The pain results from distension and traction of the peritoneum and uterocervical supports during contractions, pressure against the bladder and rectum, stretching and distension of the perineal tissues and pelvic floor to allow the passage of the fetus, and lacerations of soft tissue. The third stage of labor, pain is similar to the first stage. This slide shows the distribution of pain during each stage of labor. A is during the first stage of labor. B is during the second stage of labor. C is the third stage of labor. In A, you can see it radiates to the lower back and the lower abdomen. In B, you can see that it's over the lower abdomen with it centered mainly in the center area of both the lower abdomen and the lower back. In C, you see it's in the lower abdomen, the lower back, and the perineal area is much more prominent. Perception of pain threshold is remarkably similar in all, regardless of gender, social, ethnic, or cultural differences. Differences play definite roles in the person's perception of and behavioral responses to pain. Pain tolerance refers to the level of pain a woman is willing to endure. Pain results in the physiologic effects and sensory and emotional responses. The physiologic effects are: sympathetic nervous system is stimulated to respond to the intensifying pain, which results in increased catecholamine levels. Maternal respiratory patterns change in response to an increase in oxygen consumption. Blood pressure and heart rate increase. Hyperventilation can be accompanied by respiratory alkalosis. This may be seen in response to the more rapid, shallow breathing techniques used during intense pain. Pallor and diaphoresis may be seen. Gastric acidity increases and nausea and vomiting are common in the transition phase. Placental perfusion may decrease, uterine activity diminish, potentially prolonging labor and affecting the well-being of the fetus. The sensory and emotional or affective expressions of suffering often seen include emotional changes include increased anxiety, writhing, crying, groaning, gesturing, hand clenching and wringing, and excessive muscular excitability throughout the body. There are different factors that affect the response to pain. First, there are physiologic factors. A history of dysmenorrhea is a factor that may increase pain in childbirth, as these women tend to have higher prostaglandin levels. Women who have back pain with menstruation may experience back pain during contractions. Fatigue, interval and duration of contractions, fetal size and position, rapidity of fetal descent, and maternal position can affect pain response. Culture and religious beliefs can determine how a woman perceives, responds to, and manages pain. Women with strong religious beliefs regarding response to pain may accept it as a necessary part of childbirth. Anxiety is associated with increased pain during labor. Mild anxiety is normal, but excessive anxiety and fear cause more catecholamine secretion, which increases muscle tension and magnifies pain. This will slow the labor process. Previous experience with pain in childbirth may affect perception of pain in childbirth. If a previous labor and delivery was difficult, the woman may describe the pain of early labor as the worst it can be. The gate control theory of pain sensations travel along the sensory nerve pathways to the brain, but only a limited number of sensations can travel through these pathways at one time. Using distraction techniques, focal points, imagery, music, massage, or other methods can reduce or block the pathway to pain. Making sure that the patient is comfortable is a method of assisting with controlling pain. If one's needs are met, they are more comfortable. Support is another way. If a woman has a support person who provides physical, comforting, facilitates communication, and offers information and guidance to the woman in labor, this is an invaluable resource. The environment also has an impact on the way that the woman experiences pain. Environment includes the people present and the physical space. Nonpharmacologic measures are often simple, safe, with a few adverse reactions, and inexpensive. They provide a sense of control over childbirth. However, these methods require practice for best results. Try a variety of methods and seek alternatives, including pharmacologic methods, if the current measures used are not successful. One non-pharmacologic method that has been around for some time is the prepared childbirth. There are several different methods of childbirth preparation. Older methods include the Dick Reed method, the Lamaze method, and the Bradley method. These are still around but are focused more on assisting women with developing a birth plan that fits their philosophy and inner knowledge. More current methods were developed by Birthing from Within, BirthWorks Association of Labor Assistants and Childbirth Educators, Childbirth and Postpartum Professional Association, and Hypnobirthing, and these are just a few. All are designed to foster a woman's confidence in giving birth. Alternative methods include relaxation, imagery and visualization, breathing techniques, effleurage and counterpressure, touch and massage, applications of heat and cold, acupressure and acupuncture, transcutaneous electrical nerve stimulation, water therapy, intradermal water block, aromatherapy, hypnosis, biofeedback, and music. Breathing techniques are highlighted in your book. Please review these. Pharmacologic pain management should be implemented before pain becomes so severe that catecholamines increase and the labor is prolonged. With some women who have a birth plan to do this naturally, this could be a problem. It is important that the nurse is able to explain the physiologic reasons that this might not be the best thing to do and to go without pain medication. Combinations of pharmacologic and non-pharmacologic measures increases pain relief and creates a more positive birth experience. There are different methods of pharmacologic pain relief. Sedatives relieve anxiety and induce sleep. These may be given to a woman who is experiencing prolonged latent phase when there is a need to decrease anxiety or promote sleep. Barbiturates such as secobarbital, Seconal can cause respiratory and vasomotor depression in both the woman and the newborn. If birth is expected in 12 to 24 hours, these should be avoided. Phenothiazines such as promethazine, Phenergan, do not relieve pain. In the past, they were given to enhance the effects of opioids to decrease anxiety and apprehension, increase sedation, and reduce nausea and vomiting. However, it has been shown that Phenergan actually impairs the effects of opioids. Reglan has been shown to effectively potentiate the effects of analgesics. Benzodiazepines such as diazepam, Valium, and lorazepam, Ativan, when given with opioid analgesics, seem to enhance pain relief and reduce nausea and vomiting. However, there is a major side effect in that the mother may experience amnesia. Diazepam disrupts the thermal regulation in newborns, making them less able to maintain body temperature. It would be important if one of these were administered to have Romazicon on hand. Romazicon is a benzodiazepine antagonist which can reverse the sedation caused by benzodiazepines. Narcotics are also given during labor. Systemic analgesia can be administered in intermittent doses either by IV or IM, by a healthcare provider, or by the patient herself with a patient-controlled analgesia pump or a PCA pump. The purpose of analgesia is to alleviate the sensation of pain or raise the pain threshold. Opioids provide sedation and euphoria, but the analgesic efforts in labor are limited. In addition, all opioids have undesirable side effects, the most serious of which is respiratory depression. Other side effects include sedation, nausea and vomiting, dizziness, altered mental status, euphoria, decreased gastric motility, delayed gastric emptying, and urinary retention. Opioids readily cross the placenta and can cause profound effects on the fetus, such as absent or minimal fetal heart rate variability during labor and significant neonatal respiratory depression after birth. Opioids should be used with caution. Examples of opioid or narcotic agonists are meperidine, which is Demerol, fentanyl, and there are narcotic agonists-antagonists may be given, and an example of them is Stadol or butorphanol. If narcotics are used, it is important to have an opioid or narcotic antagonist such as naloxone hydrochloride or Narcan. Please review these medications in your textbook. Nerve block, analgesia, and anesthesia. A variety of local agents are used to produce regional analgesia that produces both analgesia and motor block, and regional anesthesia that provides complete pain relief and motor block. Most are chemically related to cocaine and end with the suffix "caine." The pharmacologic effect is to temporarily interrupt the conduction of nerve impulses. Common agents are bupivacaine, which is Marcaine, chlorprocaine, which is Nesicaine, and lidocaine, which is Xylocaine. Local perineal infiltration anesthesia may be used when an episiotomy is to be performed. 5 to 15 milliliters of lidocaine into the skin and subcutaneously into the region to be anesthetized is used. A pudendal nerve block is administered late in the second stage of labor and is useful if an episiotomy is to be performed or if a vacuum extractor is to be used. In this diagram, this shows the site of in A, it shows the site that is affected with a pudendal nerve block, and B shows the site that is affected with an epidural block. When spinal anesthesia is used, an anesthetic solution containing a local anesthetic alone or in combination with an opioid agonist analgesic is injected through the third, fourth, or fifth lumbar interspace into the subarachnoid space. In this diagram, you see the location in A. This is the location of where they would put the spinal block. Low anesthesia may be used for vaginal birth but is not suitable for labor. For cesarean birth, the anesthesia level is from the hips, T10, to the nipple, which is T6. On A, you also see the location of where they would put the epidural block, and instead of going into the subarachnoid space, it will go into the epidural space. These pictures show the methods of positioning a patient to receive spinal anesthesia. Marked hypotension, impaired placental perfusion, and an ineffective breathing pattern may occur during spinal anesthesia. Before administering the anesthetic, a bolus of IV fluid, usually 500 to 1,000 milliliters of lactated ringers or normal saline, is administered. Maternal blood pressure, pulse, and respirations, as well as fetal heart rate, should be documented every 5 to 10 minutes. The signs and symptoms of maternal hypotension with decreased placental perfusion can be found in your book. Please review these. One complication of spinal anesthesia is the post-anesthesia headache that occurs because the dura is punctured, leading to a leakage of cerebral spinal fluid. You will see this if the mother sits up and suddenly complains of an intense headache that is relieved when supine. The treatment could be a blood patch. You see the procedure for a blood patch on this slide. A needle is inserted into the location of the spinal anesthesia. Maternal blood is drawn from her arm and then injected into the back where the clot forms, sealing the leak. You can see here where they would inject the blood and it would seal the leak. Conservative management may also be used and includes oral analgesics and methylxanthines such as caffeine or theophylline. Methylxanthines cause constriction of cerebral blood vessels and may provide symptomatic relief. If no complications occur after the procedure, the woman is instructed to avoid straining or coughing for the first day after the blood patch and is taught to avoid NSAIDs for 2 days, drink plenty of fluids, and observe for signs of infection at the site and for neurologic symptoms such as pain, numbness, and tingling in the legs and difficulty walking or with elimination. Epidural. Pain relief can be achieved by injecting a local anesthetic, either bupivacaine or ropivacaine, and an opioid analgesic, either fentanyl or sufentanil, into the epidural space. The goal is pain relief without motor impairment. Epidural is the most effective pharmacologic pain relief method for labor that is available. Positioning is the same as for the spinal block. As with the spinal, most facilities infuse 500 to 1,000 milliliters of either lactated ringer or normal saline prior to the procedure to avoid hypotension. If hypotension occurs, either phenylephrine or ephedrine are given to increase blood pressure. The fetal heart rate and pattern, contraction pattern, and progress in labor must be carefully monitored. The most commonly used method is a continuous epidural block in which a catheter is placed into the epidural space and a programmed pump is used to control dosing. In your book is a box that lists the side effects of epidural anesthesia. One of the most common is itching. Benadryl may be administered if this side effect occurs. This concludes your lesson on pain control in labor.